I'm excited to be with you all today because what I want us to do by the end of our time together today is to think differently about how we go about our full arch implant treatment. Because I think a lot of the times, us as dentists, we tend to think the same. We treat people the same way, we do things in very similar manners, and it can be a very difficult thing for a lot of patients to discern our practices from every other practice that surrounds them. And it's for that exact reason that I would really like us to think differently. Now, we're going to look at 3 different ways we can think differently in this presentation regarding full arch. And what they are is the following. We're going to think differently about the way we do our diagnostics and about using alginate impressions or standard impressions on day 1 with our patients. We're going to think differently about the way we do surgery and just not flapping the case open, planing the bone, and going ahead and putting the implants in. And we're going to think very differently about the way that we do the final restorative work for this type of treatment. So let's begin with this. How can we think differently about the diagnostics? And what I want us to start off thinking about is this, is why do we start out this way with our patients? Why do we begin a relationship with our patients by starting off with an alginate impression or another type impression this way? Because if you look at the data by Hacker, and there's a variety of other people that look at this as well, there are certain things that our patients just really don't like getting in the dental chair. And we know what the biggest one and the thing that they dislike the most is, and that's the injection. We understand that. But if you look at this, the second thing that they dislike the most, and on the same order of magnitude as the injection, is actually receiving impressions. Now, this is one of those things that we're just all so used to that we don't even think about it. But this truthfully is something that our patients don't like. And that's for that reason that we want to create a different patient experience. If you also look at some of the intraoral scanning data by this paper from 2014 and this Brzezinski paper from 2018, what they show is overwhelmingly, when it comes to initial impressions, patients prefer receiving an intraoral scan for that initial visit versus receiving a conventional impression. And the Brzezinski paper is an interesting one because it also showed that patients would seek out providers that provided this type of care with an intraoral scan. And that's the first thing that we want to be able to do with our patients is we want to create a different patient experience for our full arch patients and start off that patient experience with an intraoral scan. Now, with these, we need to make sure that we're scanning all of the anatomy that we're going to need for full arch. So we're going to spend a lot of time making sure that we get all the soft tissue, that we're getting back behind the teeth. If we need to get back to the tuberosity regions or on the lower to the retromolar pad areas, we need to make sure we're getting all those different areas so that we can have all the information to be able to move forward from a full arch arena. Now, especially here in the front, I usually try to get the mucogingival junction very well so we can see where the soft tissue is and where the mucosa is, and then we get the palate and the rest of things to go from there. And it's not just capturing the anatomy and making sure that we get a good pre-op scan, but it's also using our scanner in such a way that it will actually ensure that we're getting the best possible, most accurate digital model out of that. And we've actually spent a lot of time researching these things as to how to best scan these cases. And when we look at this, basically what we've found is the most reliable thing for the vast majority of scanners is the following. We usually start off going all the way through the lingual of the entire arch and really setting the arch that way. Then we come back from an occlusal perspective, and then the third pass is going from a facial perspective. And then we're going to fill in any little voids, any little gaps, any spots that we've missed in those initial passes through that time. Once that gets set, then we're going to go ahead and fill in the palate and fill in the soft tissue. And this can be best done either this way where we're going back and forth, or you can go straight down the mid-palatine suture and then roll up from either side to fill in the rest of the stuff. But what this allows us to do is it allows us to get the most accurate possible scan because this is the basis of every single thing that we do moving forward. And it's not just getting this very accurate scan, but what we also want to do with our patients as part of creating this different patient experience for them is we want to then sit them up and show them what is actually going on in their mouth, because they've never seen their mouth this way before, and we can really help them make sense of some of the problems that we have. They've never seen a furcation like that in their mouth before. They've never seen how tightly their teeth come together, and that's the reason why there's bone loss and the teeth are worn down and they're moving. And it really makes the patient understand what is going on significantly better in their mouth, and helps create a very different patient experience for them. Now, we take all of those things that we take on that first visit, which is our preoperative scan, and we take a CBCT of our patient at that very first visit. And then what we do from there is we will go ahead and make a full contour wax up of our teeth, either us or our lab partners, and then we're going to merge it all together in Simplant. Because in my honest estimation, I think surgery and diagnostics and pros are all one thing to treat our patients. Sometimes we think of them as different modalities, but all they are is they all come together to be one byproduct so that we can go ahead and treat our patients the best way forward. Now, looking at doing things differently from a patient experience, again, with the surgery, is this way. Once we have it all integrated together in Simplant, we can sit down with our patients, show them what their preoperative condition is, show them where they're going to go with the teeth that we want to put in there, correcting their occlusal plane and whatever things that we need to do there. And then, depending if they really want to get in and know all the nitty-gritties of their treatment or not, we can go ahead and show them how we're going to create the space for the restoration and how we're going to get the implants in exactly the spots that they want through our surgical guide. And what this does is this really helps get the patients on board with this type of treatment and gets patient buy-in and moving forward and creating a very different patient experience for them. The other thing that this allows us to create a different experience is in our referral process, because we can do the exact same thing and make these videos and send them over to our referring docs and say, look, thank you for sending over Mrs. Jones, Dr. Smith. What we're going to do is this is where we're going to place the implants. These are the types of abutments we're going to put on. These are all the areas that we're concerned about and we're looking at. And if you get to an area that really concerns you, you can go ahead and spend some time on that, change the view on it so you can look at it. Again, this one, she has a moderately large incisive canal. And so we can say, look, we're going to put this here so it's away from the incisive canal. And this is the type of treatment that we're going to do on your patient. Thank you so much for the referral. And it's a very different experience than just sending over the sheet of paper saying, hey, we saw your patient. Thanks for the referral. We're going to do some implants on it. Now, besides creating these different experiences for our patients and for our referring docs, why would we want to use a guided modality versus doing it how we've always done, which is just opening up the arch, flattening the bone, and placing the implants? Well, if you look at the data on these things, we'll begin with a paper by Jonas. And I really enjoy this paper because what they have in this one is they've compared freehand surgery to pilot guides to fully guided surgery. And what you can see when you look at the apical global deviation, that's how much it is off from the plan. We see that fully guided surgery is significant, will get your implant significantly closer to where you have planned it than we can achieve with freehanded surgery, to the tune of about 1 millimeter from fully guided to about 2 millimeters with freehanded surgery. And again, this holds up in most of the systematic reviews you see out there as well on these things. Now, I think one of the best papers that has been written on this topic actually comes from Verkruysen from 2014, and they did the same thing. They looked at full arch treatment, fully guided on our left, fully freehand in the middle, and then what they called template assisted, which was a duplicate of the denture or a pilot guide. And what they looked at was the similar things. When you look at the lateral deviations of these things, again, about 1 millimeter or so from the fully guided, roughly about 2 millimeters, a little over 2 millimeters for the freehand, and 1.77 from the template assisted or pilot guides. And similar thing, we're closer on the depth as well. 3/4 of a millimeter for guided, 1.25 for freehand, and a little over 2 for the pilot assisted. That's why on our particular patient, I chose to move to a guided surgery for her because, again, we really wanted these things in a very precise location to support the teeth. And it not only is good for our patients from an accuracy perspective, but when you look at Yana's papers, Almarfini's papers, and multiple other papers, fully guided surgery is actually more efficient from a time perspective as well. And it's not just the surgery time that I'm concerned about and that is important to me. What also is important to me is the actual provisionalization of these cases. Because to be truly honest, that's honestly where my treatment begins to slow down and it takes me more time, is in the conversion prosthesis step in building the provisionals for the patients at the time of surgery. And what we can do with our Simplant plans through Atlantis is able to provide for us this file called the Immediate Smiles digital file. And what we're able to do with that file is they send us multiple files like we see here to be able to create our pre-op provisionals before we've even laid a hand on the patient. And what these different files are, if you see on the right, that's showing where our abutments, and again, we're planning these things with our final SmartFix abutments on there, but it's showing exactly where our abutments are coming through. The middle one is showing where it's coming through relative to the bone, and again, on the left is where our wax-up is. We can combine all those together in laboratory software to go ahead and design provisionals that have ready-made holes already in there so that it can make the provisionalization of these cases much more predictable and much more efficient from a time perspective. Now, the patient wears that, the patient goes out and heals, and then we get to the restorative aspect. Now, I think this is where, to be truly honest, most of us all think the same, okay? We go on this general workflow with all of our patients. We take conventional impressions, we make a model, we have our verification jig, we go ahead and make a wax rim. All this stuff gets sent to the lab to be able to create the bar. The bar comes back for try-in. We sometimes do a bite on that. Then we have our wax try-in, and then finally, we get to our final. My goal today is to hope that we can think differently about how we can do these things, okay? And the ironic thing about all of this is there are multiple steps where these are now going in scanners to be scanned to create that bar, to create the teeth, and do all the different things there. And so it's at this point that I think that we should be looking at doing these cases completely digital. Now, I know to a lot of you that are watching this is something that you all just kind of go, can't believe he's talking about this, and this can be blasphemy in a lot of circles. And to be truly honest, I thought that way as well. But these scanners have become so accurate, and we'll look at that in a minute, they become so accurate that we can reliably do these cases from a digital perspective. Now, how do we do it? How you begin is you're going to want to scan the upper, the lower, and the bite on this particular patient, okay? Because the uppers are conversion prostheses. Okay, we're going to scan those three different things before we start scanning anything relative to the implants. And one of the key things when you're scanning these cases is when you scan the opposing arch, always use your articulating paper, have them go tap, 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 tap. That way you can verify that those marks are the same as they are when your models come together digitally. That way you've got a verified bite before the patient actually leaves the chair. And that's something we've never been able to do before. And we start off with these scans this way because if you look at our paper from 2019 in JERD, what you see is this. We were looking at cross-arch accuracy and accuracy of scanning with a bunch of different scanners and a bunch of different restorative materials. And when you look at these box plots, what you basically want is the smaller the things are, the more accurate things are. And when you look at the prime scan, when we looked at the cross-arch accuracy of the prime scan, so going from second molar all the way to second molar, it was down to 18 microns for cross-arch accuracy on these dentate scans. And that's why we begin scanning the conversion prosthesis or scanning the temporary of the patient so that we can set this model in such a way, this digital model in such a way that it is the most accurate scan that we can possibly get. After we have all that set that way, it's a matter of merging all the other scans to it. So we scan the soft tissue, And then we put on the scan bodies and go ahead and scan the scan bodies. And the key with this is, again, this is sped up to 1.5 times just because we've got limited time on this. But we want to make a really accurate, good scan, just like you would want to take a really accurate impression. You want to get all the soft tissue, you want to get the palate so that everything matches back together, and you want to make sure that you get your scan bodies scanned well and together on these things. And what it allows us to do is this allows all the different scans to line up so that we can have everything cross arch mounted at the occlusion which you've already worked out and at the vertical that you've already worked out as well, so that you can get a very predictable result, get a very nice passive fitting bar and restorative work because these scanners are just that accurate. Now, if we have a case like this where we don't have a bar or we don't have a conversion prosthesis or anything like this, in our study that is just in its final round of finishing for the journal, we've shown that you can get 43 microns of cross-arch accuracy for just tissue and implant scans. And what this means for us is you can still get very passive restorations and bars made for this. Again, we had temporaries made that we put on both the physical model and the printed digital model, looked for any differences in that we could find in fit. There was no differences in fit. There was no differences in passivities. We had one temporary made completely digital, one made off of the physical model. And again, when we tried both of them in the patient's mouth, again, from a fit perspective, there was no difference. From a passivity perspective, there was no difference. And again, we knew, and this is just one case, but we've shown now this is the fourth different case which we've shown working up this way. But we're able to get very nice restorations, very passive fitting restorations, because the scanners are just that accurate, and the prime scan can get between that 18 and 40 microns of cross-arch accuracy, depending on what you're scanning. That way we can get very predictable results for our patient who you saw me scanning earlier. And I think the whole purpose of this, that I hope you've been able to glean from this, is that from the full arch perspective, we can think differently and get very remarkable results and remarkably different patient experiences for our patients, so they can tell that your practice is different than every other practice that surrounds them. Thank you very much.